My name is Brendan Shi. I'm a fourth-year resident at UCLA. I'll be discussing using bisphosphonate chaperones to target the site of tissue-to-bone repair. I have no disclosures. Rotator cuff tears remain a difficult problem. They're common, more so in elderly patients, and they have a high re-tear rate, also worse in elderly patients. And if they re-tear, patients generally do have worse outcomes. A lot of this has to do with the differences between a normal and repaired enthesis. In a normal enthesis, a gradient of fibrocartilage provides a transition zone between compliant tendon and stiff bone. When we perform cuff repairs, we surgically tack tendon down to bone. And as you can see on the left in the histology slide, this doesn't recreate the gradient seen in healthy entheses. Now, enthesis repair depends on the coordinated release of growth factors. And as shown here, many animal studies have demonstrated that certain growth factors may improve both the strength and organization of enthesis repair. However, there remain questions with growth factor therapy. First, which one is ideal? Second, what is the optimal dose and timing of growth factor delivery? And third, how can we deliver growth factors to the right place at the right time? Our focus is on this last question. We aim to use a novel bisphosphonate-based molecule to target the site of tendon bone repair, and also determine if this novel molecule has any negative intrinsic effects on healing. We developed a bisphosphonate-based molecule called OFS3, which has a few key components. First, it contains a bisphosphonate moiety that targets exposed hydroxyapatite seen in cuff repairs. Second, it contains a fluorochrome that emits signal. And third, it contains a quencher, or the cargo, that's linked to the molecule with a peptide sequence sensitive to cathepsin K, a protease emitted by activated osteoclasts. So initially, the bisphosphonate is attracted to the exposed bone generated in a rotator cuff repair. In the setting of active remodeling, such as after a cuff repair, osteoclasts emit cathepsin K. This cathepsin K digests the peptide linkage, allowing the cargo, in this case the quencher, to be released, and fluorescence can then be seen. To test this targeting mechanism, we used an Achilles repair model in mice. We divided our animals into three groups. The first group received sham surgery consisting of a skin incision closure, followed by systemic OFS3 injection. The second group underwent Achilles transection and repair and received local OFS3 application at the time of surgery. And the final group underwent Achilles transection and repair and received systemic OFS3 injection after surgery. Achilles repair consisted of a 5/0 nylon suture passed through the Achilles tendon and the calcaneus. The footprint was burred prior to repair, similar to how we prepare the greater tuberosity prior to cuff repair. We found that mice that received Achilles repair had significantly higher signal at the repair site at all time points compared to those in the sham group. This demonstrates that the quencher is only released in the presence of active repair, or elevated cathepsin K levels, which allows the quencher to be released and the fluorescence to be seen. We also found that signal was equivalent whether OFS3 was given locally at the time of surgery or via systemic injection after surgery. Next, we evaluated for any intrinsic negative effects of this molecule. As we all know, bisphosphonates are not inert. They inhibit osteoclasts and may reduce the amount of bone remodeling that occurs. OFS3 contains a modified pamidratinate molecule that theoretically has low anti-osteoclastic activity. However, we needed to test this. So to assess the effect of OFS3 on healing, we divided our mice into two groups, both of which underwent Achilles transection and repair. The first group received local administration of OFS3 after surgery, and the second group received saline. At 6 weeks, we found no difference in any biomechanical testing parameters between the two groups. We next assessed the overall morphology, cathepsin K staining, and collagen alignment at 6 weeks using histologic analysis between the two groups. On H&E stain, there was no difference in the A to P size of the repaired tissue according to two blinded observers. And on immunohistochemistry staining, we found no difference in the degree of cathepsin K staining between the two groups at 6 weeks. Second harmonic generation imaging was used to visualize collagen fibers. After quantifying collagen alignment and size, we found that there was no difference in the angle, length, straightness, or width of the collagen fibers between the two groups. Hence, in conclusion, we did find that OFS3, a novel bisphosphonate chaperone, targets the tendon-to-bone repair site, whether given locally or via systemic injection, and has no intrinsic negative effects on the strength or organization of repairs. After validating the targeting mechanism, we have now conjugated the bisphosphonate chaperone to a modified BMP2. Here on the right side, you can see that the modified BMP2 does activate BMP receptors in the ATD-CD5 chondrogenic mouse cells. And we also found equal expression when testing the modified BMP2 alone versus modified BMP2 that's conjugated to bisphosphonate and digested by cathepsin K. Next, we're looking forward to in vivo testing of this bisphosphonate BMP2 conjugate. I'd like to thank my many mentors and collaborators, as well as OREF, for supporting my work, and thank you all for your time.